One of the things that I shared with Jono was that right after I was treated and went back to work in Afghanistan, I decided to take keeping the Sabbath very seriously. And while I worshiped there, and that was important, the other part of keeping the Sabbath was turning off all electronics for one whole day. And I have followed that practice, and it makes a huge difference in your stress. Just turn it off. Don't look at your emails. Pick whatever day of the week, but it makes an amazing difference in my level of stress, and I think it would for everybody else here.
Amen. Other stories or observations?
Thank you very much for a very interesting session. I just wanted to contribute. My wife and I were involved in doing a review of the Salvation Army's health work over the last 5 years. And something struck us that is incredibly obvious, but it just sort of hit us. We were looking at what interventions did the Salvation Army do well over the last 150 years. And it's dealing with addictions, alcohol, gambling, drugs, dealing with things like leprosy, HIV/AIDS, maternal and child health. What do we not do very well? We actually don't do particularly well at high-tech surgical interventions. Some of the top end, we're not the top end research universities or hospitals or technology places. What it came down to, and we were looking at that first question, how have you seen faith in action for healthy living? What it was the relational capacity that we actually enjoy doing around the world. People in our community of faith like working with people relationally. And those diseases that I identified require relationships, HIV, leprosy, maternal and child health, addictions. And I'd add to that obesity, because it's a long-term condition. It's not take a tablet or have an operation and get better. It's the long-term relational bit. And I think that's what faith communities can bring particularly, and which will be very relevant in the non-communicable diseases of the future.
Yeah, couldn't agree more. And that is to me, that was one of the things that came out. I kept thinking that it was prayer, because we're always talking about praying for people who are sick. But it's the relational part that seems to really, it's essential. Other observations? Any other stories of how you've applied this in your own? Or, I mean, how would you, how do you operationalize that? We're each running programs, and is this relationship just going to happen on its own? Yeah. Mona over here, or okay, Joel's coming.
Hi, Jean Sack, sometimes Hopkins, sometimes Bangladesh. I noticed that in our Church of the Brethren, we have anointing before extreme crises of surgery and that sort of thing. We don't anoint somebody who's intent on losing weight. And believe me, we have some Bible Belt, wide belt people, including myself. You know, I'm there just on the obesity line. But what I noticed is that when you send someone into a hospital situation with that prayer power, and my husband, who's a twice survivor of cancer, is an example, the doctors and nurses know it. And even though they don't talk about it, I think they sort of feel ordained to do better than their best. It's like visiting a senior citizen in a nursing home. All of a sudden their care improves when a deacon goes to visit. And so although it's not talked about, I think it's an effective, almost spiritual shield or enabler of getting well. There's that hopefulness of a community of prayer.
Yeah. And on that point, in survey after survey of hospital care, one of the issues is that people want more spiritual support when they're there. That's one of the services that in many places rank as actually, now these are more secular hospitals, and then there's this question of how do we get doctors Any other piece of evidence that is as much associated with positive outcomes would be in the review of systems, would be in daily practice. It's not, except in probably your organizations where you're delivering services. Yes, please.
I obviously work with my husband, but I'm also a practicing family practitioner, and I can see in my practice what your patients need that could be given by the church, and I am convinced that a lot of the prevention could be done at church-based level. Yes, the UK is very much a secular society now. It's only about 7% go to church regularly, etc. It is very secular. But people are interested in health, and we have often split the body, the mind, and the soul. And the church does that extremely well, even though we've been told not to. We do it all the time. I have to say, in one of the Salvation Army local churches I went to, they had changed the women's fellowship meeting to call it Body, Mind, and Soul. And I thought that was an absolutely brilliant way of making health, and health in a fully Christian idea of health, as in wholeness, relevant to their community. And I think a lot of places in the developing world do that almost automatically. But the Western world is not nearly as good at it. And I would really push for community-based, church-based, basic healthcare, as in health in its entirety.
Mm-hmm. Is a question up there? And I think
we'd just like to confirm their approach. That's been our approach for the last couple of years, since the data started coming in on the importance of non-communicable diseases in developing countries as well as in our country itself. And we believe also that the church-based approach is absolutely essential. In fact, we believe that's probably the only hope that we have for dealing with this slow motion disaster, as Dr. Margaret Chan of the World Health Organization has said. And that's essentially what we do in every community we go into in our country as well as in developing countries. We work primarily with the church and also with the Ministry of Health or with the local sliding scale clinic. And there's practically any church can do this. It doesn't require a great investment. To obtain a BMI on a patient, all you need is for the very best Consumer Reports scale you can get for $45. And you can get a tape measure for $4. We get fancy. We use a $170 stadiometer, which is a great gift to leave with the local church or a local clinic. But that's all you need is a $4 tape measure. So you can get the BMI. There's very few churches that we've come across, certainly in our country and in developing countries as well, where they don't have good nurses, good doctors that know public health many times much better than we physicians in our country know. And they certainly can teach the basics of nutrition and exercise. In our country, we use the CDC guidelines and the Health and Human Services guidelines as the best evidence-based approach. In developing countries, we use the World Health Organization guidelines, because every country you go into, the doctors there have had input, or the health experts there have had input to those guidelines. So the guidelines come from them, not from us. We just go in there to try to show them where the guidelines exist. So we very much agree with their approach. We know that that's effective. So.
Great example, great example. And here, but there, who's got the mic on this side? Oh, right.
I think we've got time for one or two more.
Okay.
And sorry I didn't mention this earlier. If you would introduce your name and organization.
And then, and then let's go on behind.
I'm Dr. Larry Casaza, and I'm with Hopkins and with ACAM, African Communities Against Malaria. I'm aware of non-communicable diseases, but I'm still going to be sticking with malaria. There's a lot to do out there. I spent a lot of time between Africa and now Seattle, Washington, and it's been such an abrupt, almost assault to try to work between those cultures. And what was mentioned over here about the relational factor in terms of how people get on, be it in families, in communities, it to me is so obvious in Seattle, where there's moving to that city, and I don't know how it started, but you do not look at another person. It is somehow considered embarking on their territory or whatever. And to talk to somebody, I can talk to anybody on a bus in Nairobi, and we don't even have the same language. Haven't got a thing in common, but we have a great time. And so I think that this notion of everybody plugged in with their earphones and their little iPads, which is, endemic in Seattle, whether you're poor or not, everybody is checking. They cannot step away 10 minutes from this communication cycle that they're in. So I think that so much of what was said in terms of the health and nutrition and the faith, but it's how is it that we can step in and confront and behave differently,
Right.
in public places. There's a wonderful Christian bus driver in Seattle, and he has a big sign on the front of his bus that says "Smile." And I say to people, it won't hurt you. You can smile. It's all right. Yeah,
good.
And then they smile.
Great. Can you pass the mic back one?
Sure.
And then we'll get the last. I'm happy to stay as long. Oh, did you? Oh, sorry. I thought you had a question.
Yeah, not a question.
Was I wrong? No. Yeah, go ahead.
Sambit
Or comment.
It's just a comment on something you alluded to it briefly, is both new churches that are making people believe that prayer will cure them, and it's getting like an epidemic in a lot of African urban cities, because people are so poor and they have no other way to afford health care. So we just go to those churches. So I think we need to think, how can we target those church leaders to tell people the truth? In addition to prayer, there are other things that God gave us that we can help you.
Yeah, and that's part of that whole health and wealth gospel that what the Pew Center was looking at the data for. Okay, Nancy.
Hi, Nancy Harris from GSI, and I'm on the board. I'd like to bring this wonderful presentation and some of the comments back to CCIH. And it occurs to me that many of our members are either health-related organizations or the health part of faith-based groups. They're faith-based groups that do health, or the health part of the Methodist Church or the Adventist Church. And so, given the evidence we've seen, we may want to rethink our strategy and reach out to the core leadership of the major Christian churches and say, okay, it's time that you got on board. And so there might be some very important strategic lessons in this morning's plenary. Thank you, both of you. Wonderful.